Hello, this is Dr. Michael Wehrle, and today we're going to be talking about how to do an apically repositioned flap. Now, I'm going to post this on YouTube, so a little disclaimer here, just saying, look, this is purely for instructional purposes. Yeah, there's a little bit, minimal amount of blood in here because we're doing surgery, but this is intended for dentists who are trying to learn how to do an apically repositioned flap. Now, in this particular procedure I'm going to show you, I'm going to use a very simple way to do it. There's more elegant ways to do it, I know, but what I do is I teach beginners, so I want something that is very simple, reproducible, and works every time. And that's exactly what this one does. So let's go ahead and get started. The first thing you have to do is always evaluate the soft tissue because you don't know if you need an apically repositioned flap or not. What an apically repositioned flap does is it takes the keratinized tissue that's up on the ridge and moves it more apically, hence the name. So how you know you need this is you look at the mucogingival junction, and you can do this by pushing up on the soft tissue where the soft tissue stops moving. That's the mucogingival junction. And you need 3 millimeters minimum from that to the edge of your implant. And if you don't have that, then you should do an apically repositioned flap. So what you can do here is just measure over 3 millimeters because that junction is not always going to be a straight line. So you measure it in a couple of spots and you put a little hole in the tissue just using the pero probe. So you measure with the side of it and then you go ahead and you put a little hole in there. And then after that, you just literally connect the dots with your incision. There it is. I've connected the dots. And you'll notice that this is a very rectangular flap when you're going through the attached gingiva. Yes, I know the base always needs to be wider for a better blood supply. Now, I'll tell you that on a large flap, I've never had one die because it didn't have the right base. I've never had one die, period. But that is the principle. But when you go through the attached gingiva, you need to keep it the same size. You need to keep it in a straight line because you want the top to be the same width as the bottom because that tissue is going to move apically, and the whole idea here is to surround your empty space that you're going to have in here where your implants are going to be with attached gingiva. Now, you could do this apically repositioned flap when you first place the implants or when you uncover them. This is actually uncovering where I have the beautiful problem of the bone grew over the implants, which is nice. There we go. I've uncovered the implants, and there they are. And what you do then, you put some healing abutments on there, and I just let go of the tissue to show you that the tissue wants to go back where it was, so it's going to kind of bunch up. So the whole job here then is suturing to keep it in place. Now, on this particular case, I happen to use PRF, but you do not need to have PRF in this. If you don't, the only difference is it'll heal a little bit faster and a little bit easier and a little less discomfort with the PRF. But I've never had a patient complain about this once. So this is kind of just something that we did because I wanted this. This was actually the patient's the guy that married my wife and I. So I was just going the extra mile for him. But again, you do not need to do this step at all. Just leave it wide open. That's what I do the vast majority of the time. All right, so you push that flap and you put it exactly where you want, and then suturing in implantology is all about using little vectors to keep this tissue exactly where it is. So you looked at the first side on the left, I'm just holding it in place, and then the second, I have sutured it into place. And notice those sutures are all kind of pulling downward a little bit. That's because we're keeping the tissue from riding back up. That tissue in the middle is called the Donati, where you go through the buccal, out the palatal, back in through the palatal, out the buccal, and you leave the loop hanging in the palatal. And then you take the needle through the palatal before you tie it. And that has a downward force then because that loop goes and pushes down on the tissue and holds it down in place as long as you don't pull too hard. And all of this, that's why I use PTFE, so you have an adjustable tension on this. That tissue is now in place, and it's going to heal right there. See the little gaps between there that are filled in right now by PRF? Usually you'll just see bare bone looking back at you. I had a patient's doctor once ask, isn't that going to get necrosis and die in this, that? Well, what happens when you guys do an extraction? You got a little bit of bone left there, and it's exposed. It fills in. If you're doing multiple extractions and you see the interseptal bone exposed, it's all going to granulate over, and it's going to do it very quickly and form tissue. Again, it'll do it with PRF or not with PRF. It doesn't matter. It's going to do it either way. All right, so here's us healing now 1 week post-op, and I'm just showing you. It looks like hamburger. We love that hamburger. See how that's all granulated in and filling in? And look how nice and beefy that is to the buccal. That's what we want. 2 weeks post-op, just a little more healing. Now this is 2 months post-op. Look at that nice tissue all the way around. See, when you look at that from the buccal, it's got tissue all the way around it. Now, nice good attached gingiva. There we go. Thank you so much for watching, and this is my information. If you guys want to do a course at the at my center down in Puebla, you can go to my website and sign up. And if it's for one of my students who've already been there, hey, love that you came down. Look forward to having you again, and send all your friends. Thank you very much. Goodbye.